Okay, it's my great honor to invite Dr. Salvatore Colangelo as the next speaker. Professor Salvatore Colangelo is currently the medical director at Ospedale San Giovanni Bosco Hospital at Torino, Turin, Italy. His areas of expertise including coronary angioplasty, coronary occlusions, arterial hypertension, and chronic total occlusions, etc. Professor Salvatore has participated in numerous Italian and foreign articles and has also attended scientific congresses, including the European Congress of Interventional Cardiology. Professor Salvatore will present the role of microcatheters in antegrade and retrograde approaches. Let's welcome. Please, okay. Professor Salvatore, can you share your screen now?
You can see?
Yes.
Okay.
Thank you.
First of all, let me thank once again BrosMed and my Italian distributor Microcatheters for the invitation to this meeting. It's really a pleasure for me join with all of you. And today I will share my experience on the role of microcatheters in antegrade and retrograde approaches. When we talk about CTO-PCI, we face up to this field of interventional cardiology using a schematic approach, many times summarized in algorithms like the hybrid one suggested by the American colleagues and the global one that was presented here and published in 2021. But which is the most important key point, the first key point in the CTO-PCI, and is a good angiogram. And how should I do a good angiogram? I do a good angiogram with a powerful and long injection of contrast media, using a good projection to visualize the vessel, using a large field of view in order to see better the connection between the donor vessel and the occluded vessel, with no panning of the table, to obtain optimal view of the distal the CTO vessel, optimal view of the donor vessel and all the track of the collateral, good views in different projections of the collateral, and several views of the occluded vessel in order to understand which is the best track to go in order to recanalize the vessel. At least one same view for the both vessels. I can show you how. This is an example of a good angiogram using a large field with no panning of the table. You can appreciate the donor vessel, the track of the occluded right coronary artery. This is a wrong projection to identify the septal channel curves. We panel, we lose the distal connection. So how would I do? This is a right projection. This is a good projection, RAO, no panning, and you can appreciate how good is the connection of the septal from LAD to PDA. I have two clinical cases to share with you. The first case is a male of 73 years old with a normal, usual risk factor, hypertension, smoking, and dyslipidemia, that in March 2021 suffered an inferior STMI, and he received during the primary PCI a DS on the right. During the angiogram, we appreciate also a critical stenosis of the circ and a CTO of the LAD. The echo of this patient was good, 46% with inferior and apical akinesia. During the cardiology stay, the patient was scheduled for elective PCI on the circ OM, and for a paroxysmal atrial fibrillation, it started with the bigger trend. 110. This is the angiogram of the primary PCI. You can appreciate the distal, the lesion of the circ and the occlusion of the LAD. In the cranial view, you can also appreciate the collateral coming from the diagonal branch to the LAD. And this is the culprit lesion of the inferior SDMI, mid-right. But in this view, you can also appreciate the collateral coming from the conus and from the ventricular branch of the right to LAD. We start on the primary PCI on right, predilating the mid-right with a 2 mm balloon, and then we insert a DS on distal to mid RCA and then to mid to proximal with this final result. Mild lesion remain on the cracks. And during the stay in the cardiology, the patient underwent the angioplasty and the standing of also of the circ and the distal and in the proximal part. And this is the final results of the circ. So we planned the CTO-PCI of the LAD in November, and we start using a standard catheter for angiogram, not a guiding catheter for right for the contralateral injection, and this is a good projection to appreciate the connection of the right to left, and we start always injecting the donor vessel, and when we have visualization of the occluded coronary, we start injecting the antegrade part. So you can here we have the LAD, and then we inject the antegrade. Two views. This is the right, and we see that the occlusion is very short, and the LAD is opened. So we go. Considering that we have just a epicardial collateral from the right, not a good collateral coming from the septal, we start using an integrated approach. And in this case, we use a Pronavi 19 to do the proximal cap puncture. I was guided. So we have a wire on the diagonal branch, we have the HIVUS in the proximal LAD, and after reach the proximal cap with the Pronavi, we switch the standard workhorse wire with a Gaia 3, and we try to do the puncture of the proximal cap. The contralateral injection is helpful to understand where is the wire, but we have not in the right position. Then with the Gaia, you can see now we do the check, and we are in the vessel, but not in the lumen. So why use the Pronavi? As we said, we said before, the Pronavi has a very, very exceptional pushability and durability in the calcified lesion. I started using this microcatheter almost 1 year ago, and I'm very confident in this case to have a really helpful microcatheter in the antegrade crossing of the CTO. Why? Because the tip profile, as previously heard, is very good considering the competitor that we normally use in our cath lab. So Pronavi with remains in the proximal LAD, and we're using a more heavy wire, Warrior 14 grams, but even the 14-gram Warrior wire cannot succeed in crossing the occlusion. So we move to the retrograde, and for retrograde approach, we use a Caravel as a microcatheter, but we did not succeed to cross the epicardial collateral from even from the conus and from the ventricular branch. So we start to test the septal with a SUO 03, and as you can see, this is the real-time crossing. The SUO engaged a septal and they cross really easily the septal, reaching the distal LAD in really short time. Then we pushed the caravel, but the caravel was ineffective to go in. Then we switch our microcatheters to the Pronavi 19. This is the septal, so it's not an epicardial. We have confident to go with the microcatheter like Pronavi, and we have just some trouble in the distal part. But after that, the Pronavi go easily into the septal branch up to the proximal, up to the mid LAD, as you can see. And when we arrive here, then we have to do the distal cap puncture. Gladius, Rider, Gaia 3 was ineffective, and we used the same Warrior 14 that we used the Antegrade to do the distal cap puncture, as you can see, all in real-time registration. Some attempt, but then the wire went in. And after that, we put the IVUS in the proximal LAD, and we check that this retrograde wire was into the vessel. You can see the wire go really close to the antegrade wire, and the IVUS confirm the right position of the wire. This is the bifurcation from diagonal to occluded LAD. This is the bifurcation LAD to circ, and the wire is perfectly in. And this is the ostial left main, with the wire is right into the vessel. And considering the right position of the vessel, of the wire go easily into the antegrade guiding. And as you can see, and after that, we are checking with the IVUS the position. We are pulling back the IVUS. We are now in the guiding catheter, and we check that the wire is in, and the wire go into the antegrade guiding catheter. After that, we strap the retrograde wire with a balloon, and we push the Pronavi microcatheter into the antegrade guiding in order to do the externalization with the long wire, in this case with the RG3 wire. After the externalization, two direct eluting stent was inserted in the proximal, and this is the final result. There's no plaque over there. This is just endothelial dysfunction. We check by IVUS, and we have a wonderful result of the recanalization. Second case is a male of 67 years, some risk factor as usual, that 3 years ago suffered an NSTMI, we found a 90% LAD ostial lesion, and the patient received a drug-eluting stent on left main to LAD. 3 years later, once again NSTMI, and they perform stenting of the distal RCA. During the angiogram, we found a critical stenosis of distal LAD and a CTO of the circ. The echo was good, 53%, just hypokinesia of the apical and a mild matter regurgitation. So we plan an elective CTO-PCI of the circ. This is the angiogram of the second NSTMI in March. You see the stenosis of their distal right. And this is the left. Good results of the stenting on the left main to LAD. The lesion of this is the lesion of right, and this is the lesion of the LAD, the distal LAD, and the occlusion of the circ. So we move to the stenting. We put a stent over there in the right distal, good results. And we plan here we have the procedure of the elective CTO-PCI. First of all, considering that we have collateral comings from the LAD to epicardial to the circ, we treat the distal LAD in order to have no trouble during the recanalization, during the positioning of the microcatheter. We use the caravel as before for the epicardial, and this is the tip injection of the caravel to assess the track of the collateral to the circ. Then real-time crossing, the suo tray was ineffective, so we use a cyan blue. This is the real-time crossing also of the cyan blue in this collateral. And after we reach the proximal, the mid-circ, pushing the microcatheter into the epicardial collaterals. You see, now we are stuck, but we push a little bit more the microcatheter and we go in easily. After that, we switch the wire from cyan blue to gladius, and the gladius went easily into the plaque, into the occluded circ, up to the proximal part. And then pushing a little bit more the microcatheter, we re-enter the stent on the left main LAD with the same wire. We are in now into the stent. At this point, we have no space to go with the retrograde microcatheter because the long way of the epicardial collateral cannot allows to go with a long mic. Even with a long microcatheter, I have not the 162 Pronavi in this case, so I need to in this case I snare the gladius, the retrograde gladius into the antegrade guiding catheter, and I push on this gladius antegrade microcatheter. In this case, we use an angulated supercross 90 degrees, and as you can appreciate in this video, we have a retrograde microcatheter that is the longest one that I have, and then my radiologist gave me the 155 microcatheters, but I cannot reach the LAD and the left main, so I stop here, and this is the supercross that antegradely go from the stent into the hostel circ. We have a gap, but into this gap we cross with a RG3 from retrograde to antegrade. So we realize the externalization of the retrograde wire coming from the retrograde to antegrade in this very teeny space. I am happy to do that because I have now a circuit with the RG3, but no microcatheters went into this part because there is a calcification. There is a very calcified chronic occlusion, and no microcatheters could go in. No microcatheters except the Pronavi, and this is the Pronavi 19 that was pushed in. And the Pronavi succeed to go into this part and then to the distal circ into the OM. And now I'm really happy to do that with this microcatheter. And after the crossing of the Pronavi, I do nothing more than go with a balloon. And we start with a small balloon, 1 millimeter, 10. And this balloon go in after the crossing of the Pronavi. The balloon went in to the distal, and we start dilating the occluded tract. And I show you the crossing of the stent after the dilation also of the struts of the stent on left main LAD. So at this point we do standing on the circ to OM, standing on the proximal circ, and to conclude and to finalize the PCI, I need to put another stent from left main to circ, but I cannot put with the circuit because if I do, I jail the retrograde wire and the retrograde microcatheter. So before stenting the left main to LAD, I pull back the RG3, I pull back the microcatheter, and from one guiding catheter, I put a wire into the circ, from the other, I put the wire into the LAD, and then I put the stent from LAD, from left main to circ, concluding the full lot of this procedure. So this is after recrossing of the wire, we do a kissing, and then a part of the left main, reaching this wonderful final results of the circ with no damage of the epicardial collateral after the crossing of almost 3 microcatheter. So what is my take-home message now at this point? You need to know that how to do, yes, it's really important, but the most important thing for me is to know the features of the materials, and particularly in the CTO, in the field of CTO, microcatheters and wires must be well known, because we need to use the best option, the best microcatheter, the best wire in the worst scenario. This is the most important thing for me, and this is what I would share with you. Thank you so much.